From the Cambridge Biomedical Campus Wellness Campaign, I'm Gill Wilson, and wherever you are in the world, welcome. The desire and the need for wellness is universal, and these webinars are not just for the 20,000 plus people working on the Cambridge Biomedical Campus, they're for everyone. So please feel free to share the links far and wide. Today, I have great pleasure in introducing Dr. Susanna Unsworth, who is a British Menopause Society registered menopause specialist, bit of a mouthful. She trained in Cambridge, worked as a GP for nearly 10 years, and then decided to focus more on women's health. Currently, among other things, she is a specialty doctor in the breast unit at Addenbrooke's Hospital, Cambridge, which includes managing menopause in women after breast cancer. Susie also runs Cambridge Women's Health, which is a dedicated online private menopause clinic. Now, please put any questions as you think of them in the Q&A as we go along, and then Susie will attempt to answer them after the presentation. So with no further ado, I'll hand over to her. Welcome, Susie.
Thank you. Thanks, Jill, for that introduction. And thank you for inviting me to talk to you today about menopause. So I've entitled my talk today, Everything You Ever Wanted to Know About Menopause. Now, I think maybe that's a bit of a tall ask to answer completely, but hopefully you can all take something away from today's presentation. And as Jill said, I'm quite happy to answer some questions at the end. So this first slide is just a little introduction to me, but Jill's already kind of covered that really. But just to say, I trained locally and actually work at CUH in the breast unit, but I also work as a community gynecology GP in Saffron Walden, and also as Jill said, I run my own menopause clinic separately. So what I thought I'd do really at the start was just to talk about what menopause is, because I think a lot of time the word menopause is used for interchangeably, sort of to mean quite a lot of different things, and I think it's useful to get a proper understanding of what exactly we're actually saying when we say the word menopause. So what we're really saying is the term menopause means permanent cessation of the menstrual cycle, and it's the time of your last period, and essentially that is made retrospectively, so you have to have gone 12 months without a period, and that is the point at which we say that is your menopause. Comes from Greek menos, which means month, and pausos, which means ending. And that's kind of what the term means. But there's lots of different phrases that you might hear used in lots of different settings. And I thought I'd just go through a few of those, because sometimes it can be a bit complicated to understand what people actually mean when they say different things. So perimenopause, I think, is a term that's used a lot more now, and I think it's a really helpful term because it really describes women that are experiencing symptoms of hormonal changes, but they're still having their periods. So they've not gone through menopause as such, but they could still be getting quite a lot of symptoms. And classically, I think these are the women that don't really get identified as being menopausal or having hormonal change, and sadly sometimes get treated incorrectly because of that. There's other phrases as well, so pre-menopause and post-menopause. I mean, that really just means kind of what it says, really. So pre-menopause is anything from the moment your periods start to the moment they stop, and then post-menopause is everything beyond your period stopping. And for some women, that can actually be about a third of their life in that phase. So it's really important that we think about this as a health sort of transition and doing things to maximise health going forward. And I'll talk a bit more about that further on in the presentation. Early menopause, so that's when women actually experience menopause between the age of 40 and 45, and that's when they actually have menopause itself, so their periods stop. Women can experience perimenopause well, in their early 40s, sometimes even in their late 30s. It can actually start at least 10 years before menopause itself. So early menopause is when you're 40 to 45 and actually your periods come to an end. You might have women as well who've had a surgical menopause. They might have had surgery to remove their ovaries for various different reasons. They might have an induced menopause, which is where we give medication that actually puts them into sort of a medical sort of menopause, which can sometimes be used as treatment for things like endometriosis. Or you might have women who have suffered menopause as a consequence of some medical treatment that they've had. So we call this iatrogenic And that's often related to things like chemotherapy that can trigger a menopause in women who've undergone that sort of treatment. The last thing on this slide that I've put is something called premature ovarian insufficiency. Now, this is where menopause occurs under the age of 40, and it used to be called premature menopause, but we've sort of moved away from that terminology a little bit now. But this is a really, really important diagnosis for women. So if there's anybody listening today who is under 40 and their periods have stopped, it is something that I would strongly encourage you to speak to your doctor about, because it does warrant further investigation and also management because of health implications that it can have for the future. So they're the different terms that you might hear, and like I say, sometimes they can be used a bit interchangeably. So this slide I've put up, and if we're all in a room together, I might be saying, can you all put your hand up and tell me which of these women you think might be experiencing menopause? And classically, I suspect most people would probably say the woman in picture B. But as these sort of slides, yeah, it's a bit of a trick question, really. So any of these women could potentially be experiencing menopausal symptoms. The woman in picture A, she could well be going through the premature ovarian insufficiency that we spoke about. And the lady in picture C, you know, she's potentially a few years beyond her actual menopause, but she could still be experiencing symptoms related to it. So I think the key message from this slide is really that there's no specific age that menopause affects women. It can affect women at any age. And actually the youngest woman I saw when I was training was actually 16. So I always get quite sad when women tell me they've been told they're too young to be going through menopause, because that isn't true at all. There is obviously the most common age at which women experience menopause, and in the UK that's about the age of 51. But anything above 45 is considered normal. I thought I'd put this slide up just to kind of give you a little bit of an overview of what's happening with the hormones, because I think it's useful to get an understanding of what is going on with your hormones in the background. And just to sort of explain the graph a little bit more, the blue shaded area is what we call your ovarian reserve. And when you get to about the age of 38, that really starts to rapidly decline. And so the level of production of hormones, including estrogen and progesterone, really start to fall. And then the other hormone, which is a green line, which is called follicle stimulating hormone, which is produced by the brain, is kind of your body trying to get your ovaries to function. So the level goes up and up and up, trying to get your ovaries to function. But eventually it reaches a point where the ovarian function just, it can't function anymore, and the levels of hormone completely drop. Now, this is quite a simplified version, and actually I'll go on a little bit later to show you actually that there's quite a lot of fluctuation in the hormones. They don't follow these nice smooth curves, but that's really just a sort of simple representation of what's happening. But, you know, what does that mean for you as an individual? You know, how do those hormones changes translate to actual symptoms? Well, actually, there's about 45, maybe even more than that, different symptoms that menopause can cause. This poster that I've put up on this slide is something that's been introduced in the last few years, put up in sort of GP waiting rooms and various other places to try and show women what sort of symptoms they might experience, so that they actually can recognise it as being part of their menopause. Because I think a lot of the symptoms many women don't really recognise as being part of menopause, and that can make it difficult for you as an individual to know what's going on and to know when to go and get help for it. So what I've put here is kind of a little summary of the main symptoms that I generally see in the clinic when I'm seeing women. So the top of the list is what we call vasomotor symptoms. So these are things like hot flushes and night sweats, and they probably affect about 70% of women. But that means 30% of women don't get them. So you don't have to be having hot flushes or night sweats in order to say that you are experiencing menopause, but they are quite common. The psychological symptoms are also really common, and I think these are the ones that I think are most difficult to identify as being part of menopause. And sometimes I think these are the early symptoms that women in perimenopause might start to experience, having never really had problems before. And often they can be misdiagnosed as maybe mental health related issues rather than being actually part of menopause. So things like low mood and anxiety are really common. Sleep disturbance. So sleep can be affected by night sweats, but it can also be affected by just the hormonal change in itself. People might feel quite irritable, sort of loss of energy, loss of confidence, things like that. And then reduced libido is something that I do hear women tell me that is a particular problem for a lot of them as well. And then there's physical symptoms as well. So joint pains are really common. Often people talk about their hands being quite painful or their feet becoming painful, but actually it can affect any of the joints. Headaches might become more common, particularly in women who maybe have struggled with sort of migraine around the time of their period. That can sometimes get worse in sort of perimenopause. And then other things like palpitations and skin changes. So as you can see, there's quite a wide variety of symptoms that women can experience. Vaginal symptoms are something that I think a lot of women do suffer with and sadly often don't feel confident talking about. So in my clinic, I will often ask people this specifically. Are you getting any dryness, any burning, any itching in the vagina? Are you finding it's painful to have sex? And the reason I like to ask that is because actually there's really good treatments to help with that. So if that's something that's bothering you, I'd really encourage you to speak to your doctor or you know, speak to someone about that. And then the last thing, periods. Obviously, we said by definition, menopause is your period stopping, but it's very rare for them to just carry on as normal and then just suddenly stop. So for most women, you'll find they might get more frequent and then they might get less frequent and they can do anything in between, unfortunately. If you do find you're getting a lot of bleeding in between your periods or you're getting bleeding after sex, that is sometimes a sign of some other problems. So I would encourage you to speak to your doctor about that. But generally, changes in periods are not unusual. So if you're getting lots of these sort of symptoms, and what I often find when women come to see me in different settings is that they will say, well, what test should I have? You know, what can I do to prove that I'm going through menopause? And actually, for the vast majority of people, blood tests are not needed. Menopause should really be what we call a clinical diagnosis. So it should be based on what symptoms someone's getting and where they are in their kind of, well, probably about their age as well, really. Obviously, I know I said before that age is not a factor, but it is something just to take into account when you're initially trying to set on a diagnosis. So anyone above the age of 45, I wouldn't be doing any blood tests in. And sadly, if we do blood tests in women, particularly in perimenopause, the results can often be really, really misleading. And I've tried to demonstrate this in this little graph to the side, so I apologise if it's a bit small. But this is showing a much better representation of what's actually happening with the hormones in perimenopause and postmenopausal women. So the very top line of that graph is women who are they're women who are just having normal periods, premenopausal, really regular cycles, and their hormones are following a really nice pattern. And if you were to check a blood test in a woman of that age, as long as you knew where she was in her cycle, you probably could interpret the levels. And that might be if you know, checking for fertility things or something along those lines. But we're not talking about those particular women here. We're talking about women who are experiencing either perimenopause or postmenopausally. So women post-menopause, the blood levels are going to be in this bottom chart where the FSH is really high and the estrogen and progesterone is really low. But actually this woman's stopped her periods for over 12 months. She's over 45. There's not really any need to do a blood test to say that that's what's going on. We know that's what's going on because clinically she's told us that's the problem. The issue is when we start doing blood tests in the woman who's potentially in this middle graph. So this is a woman who's perimenopausal, so she's still having periods, but she might be getting some of these symptoms suggestive of menopause. And sadly, if we do blood tests in her, often they're really misleading because this roller coaster sort of appearance of what's going on with the blood hormone levels. If you do a test on one day, it might say one thing, you do it another day, it could say something totally different. And sadly, what I find is a lot of women get told their blood tests were normal. And so they get told it's nothing to do with your hormones. And that's not true. It's just because on that particular moment in time, their blood levels are within the normal range. But it doesn't mean that things aren't changing. So for the vast majority of women, I discourage you from doing any sort of blood tests. It can be useful in certain situations. And I said before about women who are very young. In women under 40, then we definitely want to know what's going on with them. So blood tests in that situation are really important. If you're under 45 and your periods have stopped, it might be helpful in some situations to have some blood tests because that is obviously a little bit earlier than we'd expect. And occasionally we use it in women who are using hormonal contraception because that's going to affect your periods and we maybe don't know what's happening in the background. I've just put a little figure at the bottom of here about how much the blood tests that we normally do, which is the FSH level, actually cost the NHS. And that I think that result was, that data comes from about 2016. And I think it probably is even higher than that now. But £9.6 million is quite a lot of money to be spending on a blood test that A, is probably not needed, and B, actually might even give people the wrong results. So take home from this slide is, don't feel that you need to have blood tested to check this all out for you. But anyway, moving on from that, thinking about what can you do to help yourself. So if you feel that you're getting some of these symptoms and you think, actually, do you know, I might be approaching menopause, I think I'm probably in that perimenopause phase, there are things you can do that you don't need to speak to a doctor straight away. There are things that you can do to help yourself. And the way I sort of approach it is thinking about the long-term health implications of what menopause actually means. So losing estrogen, which is the hormone that we're generally losing, does have a negative effect on the body, because estrogen is very protective of your heart and your blood vessels and your bones. So when you start to lose that hormone, you're losing that protection of that hormone. So you want to be doing things in your lifestyle that are going to help, maintain that health going forward, and especially if you're going to be leading a third of your life in this sort of post-menopause phase. So nothing of this is out of the ordinary. It's really just thinking about lifestyle things. So eating healthily, but maybe trying to focus it on cardiovascular health and bone health. So protein-rich diet will help with sort of muscle strength, thinking about calcium and vitamin D to help with your bones, thinking about sort of low saturated fat diet, reducing alcohol. I mean, I'm not going to say to you, don't have any alcohol, but we do know that alcohol definitely makes menopausal symptoms worse. And a lot of women I see say if they drink a glass of wine, their hot flushes the next day are often worse. So it's about doing that in moderation and recognizing that the link between those. Exercise is another really important thing. So the WHO says we should all be doing 150 minutes of moderate exercise a week. But when you're approaching menopause, we need to be thinking about the type of exercise as well. So again, it's this cardiovascular health and bone health approach. So doing things that get your heart rate going, but also thinking about more strengthening and weight-bearing exercise to help maintain your bone density. And obviously I wouldn't be a proper doctor if I didn't tell you not to smoke. So smoking is definitely linked with menopausal symptoms. Women who smoke tend to suffer with significantly worse hot flushes. And like I was saying, it's about thinking about your life transition and what your health going forward and trying to maximize that. And so maybe taking the opportunity to think, do you know what, I think maybe now is a time to think about stopping smoking if you are a smoker. And then I like to talk a bit about alternative therapies, because a lot of the women that I see will have already tried quite a few things, and a lot of these things can be really helpful. Do have to think about what we know about the evidence to support them. So the two things I've got at the top here, so cognitive behavioural therapy, might sound a bit odd to use something like that to help with menopause, but actually there's good data to show it's very effective in helping with hot flushes. There was a study done in London that looked specifically at this, and they've actually produced a guide to allow you to do the CBT sort of techniques that they used in that study. And if anyone's interested in that, I can direct you to that at the end. And it can also help with mood and anxiety problems as well. And then acupuncture is another treatment that has evidence to support it. And in the breast unit where I work, I sometimes direct some of the women I see there to look into having acupuncture. And that can be quite effective at helping with hot flushes too. I mentioned diet things for just like lifestyle issues earlier, but there are dietary things you can introduce as well that can have estrogen-like effects. So certain things contain something called phytoestrogens, which are chemicals that are a bit like estrogen and have a very mild estrogen-like effect. So things like soy and flaxseed have these effects, and I'd encourage you to maybe think about increasing the amount of those sort of things that you have in your diet. I've put herbal remedies on here because a lot of women do like to go down a herbal route, do have a little bit of anxiety about herbal treatments, partly because they're not particularly well regulated, and herbal doesn't automatically equate to being safe. And I think we just have to be a little bit careful of what we're using. So I've put black cohosh on here because that is something that is often advertised as being helpful in menopause. And I think some women do find it helps, although there's not actually very much evidence to support it. The difficult thing is it's a bit unclear how it works. It can interact with other medication. So you just got to be a little bit careful with these things. And I've put this picture on the side, the THR logo, which is a traditional herbal registration. And that is something I would say, if you're going to go down a herbal route, do a little bit of research. I mean, I'm not a specialist on sort of herbal options, but I would encourage you to look for this logo, because that gives you a little bit of reassurance that what you're getting has some sort of element of regulation around it, because actually people can sell things that contain maybe not necessarily what it seems to say on the packaging. So just to be a little bit careful with those sort of things. So that's kind of a bit of a summary of kind of the alternative type things that you can do and lifestyle things. But in my clinic, I guess my main focus for a lot of the women I see is around hormone replacement therapy. And this is kind of what my main area of interest is in. So I thought I'd now just spend a bit of time talking to you about that, so that you've got a good understanding of what we mean when we talk about HRT, and also a better understanding of what the true sort of risks and benefits are, so that you're then in a place to then make a decision if it's what you feel would help you. So HRT, what do we mean when we say that? Well, we mean hormone replacement therapy, really. There's some different phrases used. I think sometimes it's referred to as menopause hormone therapy, different terminology, but I'm going to refer to it as HRT because I think most people know what we mean when we say that. And what HRT is giving somebody estrogen with or without a progestogen. That's kind of the basic situation of what we're using. And what hormones do we actually use? So for the estrogen, we tend to use estradiol, and this is actually the sort of most active form of estrogen in our bodies, and that's what most forms of HRT contain. Some of the more topical ones contain estrone or estriol. They're a little bit weaker. Most of the estradiol that we use in HRT is synthesized from soy and yam. So I mentioned on the previous slide about these containing chemicals that act like estrogen. And the structure is actually identical to our body's natural estradiol. You might have heard of some other products that contain what we call conjugated equine estrogens. So these are estrogens that were extracted from pregnant horses' urine. Yeah, I don't really prescribe much of those. Well, I don't prescribe them at all now. I might occasionally find a lady who's taking them, having been on them historically for quite a while, but they're not something that I would rush to use anymore. But yeah, people might have heard about those. And then the progestogen part. So most of the sort of standard HRT products contain synthetic forms of progesterone, which we call progestogens. Again, these are often derived from plants, but they're structurally a bit different to progesterone. However, there are two products now that do contain actual progesterone itself. So again, chemically the same as your body's natural progesterone. There's something called Utrogestan, and there's another product called Bijuve, which is actually quite a new product. And they both contain micronized progesterone. And if you take that alongside estradiol, you're actually taking what we call body identical HRT. So this might be something you've heard mentioned. So it essentially means the two hormones are chemically identical to your body's natural hormones. This is a bit different to the term bioidentical, which you might have also heard. This actually refers to types of HRT that are made in what we call compounding pharmacies, and they contain different amounts of multiple hormones, so estrogen, progesterone, testosterone, a bit of DHEA in there, really sort of varied amounts of things, and they're supposedly based on blood tests or saliva tests that women have. I would not encourage people to go down this route because actually they're not particularly well regulated in the UK, and they're not endorsed by the British Menopause Society. So we don't really know how safe they are. So they're very expensive, they're available privately, they require to have lots of blood tests that are probably unnecessary. So it's not something I would personally encourage you to look into, but it might be something that you have heard about. So that's kind of a bit of a summary of the hormones involved. But different women are going to need different sort of types of HRT, and I think a lot of the time people don't really know what sort of HRT they might need to use. So what I've tried to do here is just sort of simplify it. So essentially the first question I would be asking is have you had a hysterectomy? If you've had your womb removed and it's removed all of your endometrium, which is the womb sort of lining tissue, then we can just give you estrogen. And estrogen is the hormone that's causing most of the problems, and that's what we want to replace. And so estrogen only HRT is common, and that's what we'd use in this situation. However, most women probably haven't had a hysterectomy. And if you haven't had a hysterectomy, then we do need to give you what we call combined HRT. So this is a combination of estrogen and a progestogen or progesterone. And the reason for that is the estrogen, is, like I say, is there to help with all the symptoms. But if we give you estrogen on its own, it can stimulate your womb lining to thicken, and that potentially can lead on to it becoming cancerous changes taking place in it. So we don't want that to happen. And so the way to stop that is to use a progestogen alongside it. There might be situations where we would do that in someone who has had a hysterectomy. So if you've had a hysterectomy for, say, endometriosis, we can't always be sure that all the endometrial tissue has been removed. So we might want to give you a combined preparation in that situation. But for the majority of women, this is kind of the way we divide it. And then for the women who have got combined HRT, we often then divide them as to whether they're still having periods or their periods are finished. So if your periods are still happening, and it's been less than 12 months since your last period, traditionally, we'd probably give you what we call as a cyclical or a sequential form of HRT. And that's where you get estrogen all the time, and then the progesterone is given in a cycle pattern. And that will often make you have a bleed once a month, as you have been doing. If your periods have stopped and it's been more than 12 months, then we can actually give you both hormones all the time, and that generally will mean you don't have any bleeding. Now, this is quite a basic sort of picture here, and actually there's quite a lot of times when I will use continuous forms of HRT in women who are still having periods, and there's different reasons why we might want to do that. One of them being we're trying to even out the hormonal fluctuations a bit more. But on the whole, this might be the pattern that we'd sort of offer to women. And then thinking about what HRT products have we got in the UK, there's loads of different products available. I'm sure you've probably seen in the media recently that there are actually a lot of supply issues with a lot of the products in the UK at the moment, but hopefully that is on the way to being sorted out. But in the UK, we've got tablets, so either estrogen on their own, progesterone on its own, or a combination. We've got different forms of gel that are available. We've got patches that can come with just estrogen or combined preparations. There's a spray that was introduced a couple of years ago, which is quite nice to use. The Mirena Coil can be used as part of HRT, and this can give the progestogen part of HRT, which is really, really effective for women that might want to use, might need contraception or might be having really heavy period problems. And then I spoke before about the vaginal symptoms. And so there are actually topical forms of HRT that we use. And these are really, really safe to use. They don't have any of the risks that I'll go on to talk to you about that HRT generally has. And so if you're struggling with vaginal symptoms, even if that's the only problem you're getting, I'd encourage you to have a think about using some vaginal treatment. This is a cream called Ovestin, but there's a few other options of things that you can use. So there's lots of different ways in which we can manage that. So why am I such a big advocate of HRT? So obviously I've spoken to you about all the different things that are available, but why would you want to take it? So we know actually that HRT, from all the evidence, is by far the best treatment for managing menopausal symptoms. It's significantly better than any of the other things that I sort of mentioned to you before. And that includes both the physical things and the psychological symptoms. And it's because it's due to estrogen change. And if we can restore that, that's going to help solve those problems. But it does have other health benefits as well. So thinking about when we said before about bone health and cardiovascular health, these are the things that we know that estrogen actually helps protect you against. So thinking about bone health, so osteoporosis becomes common post-menopausally. And actually, you can now use HRT to treat osteoporosis in women under 60. And women who take HRT actually have increased bone density. So it's a good way of helping improve your bone health. Cardiovascular health, if we treat you early in your either perimenopause or early postmenopausally, it continues to provide that protection for your heart and blood vessels. There's a little bit of what we call a window of opportunity here, because if we leave it too long after your menopause, the risk of cardiovascular problems goes up a little bit. So it's about catching it at the right time. And then this other picture at the bottom is really to sort of represent cognitive changes. Now, this is a little bit of a controversial sort of issue, and I don't know whether any of you saw a television programme that was on about 2 weeks or so ago that Davina McCall presented, and they spoke about a study in that programme that has shown that women that use HRT in perimenopause have reduced risk of developing Alzheimer's disease. I think there's not really enough evidence at the moment to say that we should be using it as a way of preventing dementia problems, but we do know that women that experience premature ovarian insufficiency, if they're not treated with HRT, do have a higher chance of developing things like Alzheimer's disease. So there's clearly a role of estrogen in the brain as well, and I think as time goes on we'll know more and more about that. The one thing I do think is quite useful to point out is about just general mortality is lower in women who use HRT than women who don't. And it's most likely because of these other health benefits that it offers you. So I like to think of HRT not just about managing the symptoms you've got now, which is obviously really, really important, but also about the potential longer term health benefits that you have to gain. Obviously, there are risks involved, and I think it's really important that you're aware about potential risks, but I think it's important to make sure that you understand what the true risk is, because I think the media has been very quick to sort of really be quite negative about HRT in the past, in particular related to breast cancer. And I think this is what most women generally do worry about when we talk about HRT. So what I'm going to do now in the next couple of slides is just try and show you what the true sort of risks are of breast cancer in relation to HRT. So when we're talking about breast cancer risk, we're really referring to the combined preparations, so the two hormones that we spoke about before. And there is a small increased risk of being diagnosed with breast cancer if you use those forms of HRT. Interestingly, if you use estrogen only HRT, there's actually a lower risk of developing breast cancer. So it's not about the estrogen on its own, it's about the combination of the two hormones. And this picture, I think, represents it quite well. So these little women are how many women will get breast cancer at the age of 50 to 60 per 1,000 women. So the top line is the number of women who will be diagnosed with breast cancer for no other reason. That's what we call the baseline risk, and it's about 23 women in every 1,000. The next line down shows you how many women will be diagnosed if they take HRT. So 23 of them would have been diagnosed anyway, and there's an extra 4 women in 1,000 that will be diagnosed as a consequence of taking HRT. I think what's really important is to kind of compare this to some of the other things a bit lower down. So I don't know whether whether you can see that well, but the 5th one down is alcohol. So if you drink more than 2 units of alcohol a day, and that actually increases your risk of breast cancer more than HRT. It goes up by 5 cases, which I think is quite interesting because that's actually well within the normal recognised limits. But what's most fascinating is BMI. So being obese, so having a BMI of over 30, actually more than doubles your risk of getting breast cancer, goes from 23 to 47. So it's a massive increased risk. And this is much more significant than HRT, but often isn't really sort of portrayed in the media. So I think it's just about putting these things into perspective. There are some other things just to think about. So blood clotting is one of the other risks that a lot of women might talk about. This is really associated with oral preparations of HRT, so the estrogen part being taken as a tablet. And that does increase the clotting, the risk of having a blood clot. It's the way in which it's metabolized through your liver. But interestingly, if you use estrogen through the skin, so either as a patch or a gel, that does not have that same increased risk. At standard doses, it does not increase your risk of clotting. So women who've had blood clots before or might have a family history of that can use that absolutely fine. A couple of other things just to mention. So we spoke about cardiovascular risk and actually how HRT is protective. If you leave it too long after your menopause, then potentially it can be slightly risky to introduce HRT, and the risk of strokes and heart attacks very slightly increases. And then there's some other cancer risks that, again, are really, really small and not hugely significant, but we do mention sort of ovarian potential cancer risk, but it's an extra 1 in 5,000, so it's a really sort of small number that we're talking there. So for me, if you're considering HRT, I would say it does need to be individualised to you. There's not kind of a one-size-fits-all preparation that I would say to give to everybody, because there's lots of different factors to consider. So your medical history, whether you do have obesity, whether you've got heart problems already, whether you've had a blood clot before. Vaginal things, you know, is that your main problem? You might want to use that as a starting point, or we can use it in addition to HRT because it's really, really effective at helping with those symptoms. Contraception is important as well. So if you do have a need for contraception, HRT doesn't actually act as contraception unless it's used with the Mirena Coil. So you would need to think about that. And then other things like if you've used hormones before and had any problems with them, or really just sort of personal preference as well. You know, some people prefer to take a tablet, others prefer the sort of ease of a patch that they don't have to think about. So there's lots of different choices. I would say the gold standard is probably to give you the estrogen through the skin and use that alongside micronized progesterone, which is what we call body identical HRT. And actually, there's been recent data, which I haven't included in today's presentation, but looking at body identical HRT in relation to breast cancer risk. And actually, that has shown that there's no increased risk of breast cancer for the first 5 years of using this form of HRT. So the data that I showed you before was sort of from a combination of lots of different types of HRT. But what we're knowing now is that these newer forms of body identical HRT are actually much, much safer. I've put this slide in as well because I think testosterone is something that has become very popular recently, and there's been a lot about it. I think Davina McCall's programs have definitely encouraged people to talk more about testosterone, and I think that is really good because we know that testosterone does have a significant role in the female body. It does contribute to libido, but it contributes lots of other things as well, so muscle and bone strength, cognition, mood. So I do use a lot of testosterone in the clinic at the moment. The guidance is we should only be using it for libido, which I think is a shame because actually from my experience, most women tend to find these other things improve so much more than their libido does. There's particular groups where I think it is really important. So those who've gone through sort of surgical menopause or an iatrogenic menopause caused by chemotherapy, or those who are experiencing a very early menopause, I think have more to benefit from using testosterone. And I know I said to you before, don't do blood tests, but this is probably the time when I think blood tests should be done really. And it allows us just to calculate something called your free androgen index. And it's the only time when I think blood test monitoring is important. One thing just to point out at the moment is there are no licensed products for women in the UK. So we either have to use a male product out of license or an imported product from Australia, which is called Androfem, but that's only really available privately. So moving on, I thought the last little bit of my talk, I would just talk about menopause and how it affects women in the workplace. I thought maybe the audience listening today, that would be an appropriate thing just to talk about. So there are some real shocking statistics available about how menopause influences women in the workplace. About 1 in 10 women have actually considered giving up work due to their menopausal symptoms. 80% of women feel that their symptoms actually impact on their ability to do their job. And then 50% of women actually feel that workplace stresses can make their menopausal symptoms worse. So I think it's good that a lot of employers now are talking more about having menopause policies in place to help support women in the workplace. So this last slide I've got here is really just giving you some little hints and things maybe to think about in sort of a workplace setting. And I think the key thing I would say is just to talk to your employer or someone in HR or occupational health just about what's happening and try and be honest. If you're having to take time off work because of your menopause, it's best to be honest about it because they can then hopefully offer appropriate support for you. There are things you can do yourself. I mean, I know a lot of you are probably working within the hospital. It's not always easy to make changes to your working pattern. So doing things to avoid triggers might not be possible. Might not be possible to take regular breaks. I know I've worked in a hospital for a long time, and I know how it's difficult. But if you can make little changes like that and maybe planning your day around your symptoms. So if you know that you struggle more in the afternoon, trying to focus the sort of more challenging parts of your job in the morning. If there's things you can do like that, it just might make a difference. But getting support from colleagues, I think, is probably one of the key things. And then finally, reasonable adjustments that maybe your employer can think about. So I mentioned about planning your day around your symptoms, but whether you can actually have changes to your working pattern may be possible. More practical things like fans on your desk and more ventilation, maybe having access to water, and maybe having access to a room where you can actually go if you think you're having a hot flush that is away from everybody, just to give you a little bit of time out. And then the last thing I think maybe that might be useful in the sort of settings where you guys might be working is flexibility in uniform. That can be really challenging if you're struggling with hot flushes, if you're wearing kind of thick, heavy uniform that makes you feel very hot. you know, thinking about managing that and whether there's different things that your employer could do to try and help with that. So feel like I've rushed through kind of everything. That is the end of my presentation. This last slide is really just to say that I do offer sort of a menopause clinic independently if you felt like you wanted some additional support. And it's done sort of as an online clinic at the moment. But hopefully that has given you some information that you found helpful. And yeah, hopefully there's something that you can all take home from that. So I'm going to stop there and I'm going to stop sharing my slides.
Susie, thank you so much. This is absolutely fascinating, and that's borne out by the number of Q&A that we've got coming in and stuff on the chat. We are never going to get through it all, and maybe we need to have another session which is simply for us to go through questions, because people have so many questions. So let's have a look. I've had actually one coming on YouTube, so I'll pick that up first. Can you tell us, when does the menopause finish, if ever?
So that's quite a common question. A lot of women ask me, is like, well, when will these symptoms stop? And I would say for the majority of women, they do kind of stop after about 3 to 5 years, I would say, is the average sort of length of time that women experience symptoms. And what's happening is kind of things are resetting their balance in the background, and a lot of women find that those issues tend to sort of settle down. Saying that, I do have quite a lot of women who actually are experiencing symptoms well beyond that, and sometimes into their 60s, even potentially into their 70s. And that isn't very common, so don't want you to all go home and worry that you're going to be suffering like this forever. So it is really variable from one woman to the next, and it's difficult to give an exact figure. And then perimenopause, again, can start there at variable length of time before menopause itself. So sometimes 10 years before. I've definitely have women who've been struggling for 10 years but still having periods. So it's it can be anything, unfortunately.
Okay, Susie, thank you. Now I think we'll try and do a whistle-stop tour of asking and answering as many questions as we can, but we have had several requests for the CBT link, so if you let me have a CBT link, Susie, I will put it in the email that goes out to everybody.
I can send that on to you. It's a really useful guide, actually, because they did the study, looked at 2 different groups. So they looked at doing CBT in an actual group session, and then they also did a self-help guide which was doing the same techniques but in someone just doing it themselves at home, and they actually found no difference between the 2 groups. They both were equally effective. So actually having the self-help guide is a really good way of doing that. So I often encourage people to look at that. It can be really helpful. So yeah, I'm happy to provide you with that.
Wonderful. I've got, as I say, so many questions.
I'm just reading a couple. There's a couple that are a bit similar. So one sort of saying about the contraceptive pill, so the progesterone-only pill or the actual combined pill, can it mask or delay perimenopause? It can make it difficult to know what's going on. If you're on the progesterone-only pill, sometimes that will stop your periods. It doesn't delay the menopause because hormonal changes are still happening, but it might make it difficult to know where you are with things, because obviously your periods might have stopped because of the pill. And that's one of the situations sometimes where it can be useful to do some hormone tests. If we're thinking about how long do you want to carry on using that pill for, because there's different guidance on how long you should use contraception for. The other one mentioned about the combined pill and whether it masks or delays perimenopause. It can actually, the combined pill can actually help with perimenopausal symptoms, because actually when you think about the combined pill, it contains a type of estrogen and a type of progestogen. So it's a bit like HRT, but the hormones are a little bit different. They're much stronger, they're very synthetic, which they need to be, because they're contraceptive, they're wanting to stop you from ovulating, but because they're similar hormones, some women do find they can help with perimenopausal symptoms. So if you're on the pill and you're in, maybe you're in your 40s using the combined pill, it might be actually helping some of the symptoms. And in some very young women, I might sometimes use certain types of contraceptive pill instead of HRT, because it can offer some benefit in kind of helping with the symptoms, and obviously also it acts as a contraceptive as well. But the hormones are sort of more synthetic, so they're not the best ones to be using if we're just thinking about menopause.
Wow. And I'm just watching all the other questions come in as well. We have got so many. There was one that was about the Mirena Coil,
Yeah.
and was it necessary to have it removed in order to see if the woman's menopausal?
See if you were menopausal.
Mm.
Yeah, I would never sort of say to remove a coil just for that. I think that's really unnecessary. You can have hormone levels checked when you've got the Mirena. You can't really do hormone levels in people that are using very high doses of progestogen, so people who are having the injection form of contraception, or people who are using combined contraceptives, because that interferes a little bit with the test. But with the Mirena, you can do an FSH test, which would give us a little bit of a marker as to where you might be. The difficult thing is, like I said in the talk, that in perimenopause, the hormones are fluctuating really significantly. So it doesn't always give you the answer. So sometimes we'd say to do 2 of them, maybe 6 weeks apart, and see if there's any fluctuation in the level. But I discourage people from having it removed just to check, because most of the time that's not really necessary, and to then have it put back in is quite a significant procedure. And obviously having it removed, if you're using it as a contraceptive, then you're potentially putting yourself at risk of pregnancy. So yeah, there's I wouldn't say that I would want to remove someone's Mirena just to do that.
Is there any research about the risks of having HRT over 60? Is there any evidence that HRT helps to reduce osteoporosis, breast cancer, heart disease, etc., if started over 60 or over 10 years post-menopause?
That's quite an interesting question. So over 60 is sort of the cutoff that we have, where we actually think the risk of introducing HRT does slightly increase. Now, this does depend a little bit about when someone went through their menopause, because if they went through a very late menopause, I mean, I've had, I think the latest woman I had, she was nearly 58 and she was still having periods. So, 60 was only a couple of years later. So it's unlikely that would have had a significant issue. But there is data to show that sort of women over 60 do have a slightly higher risk when it comes to introducing sort of cardiovascular risk when it comes to introducing HRT. And the reason for that is essentially what happens when you lose estrogen is women start developing atherosclerosis, like men have, which is where you get this sort of furring up process in the arteries. If we introduce HRT and that has already developed, then potentially it can destabilize it a little bit, and it increases the risk of having things like heart attacks and strokes. So we do have to be a little bit cautious. But there is potential benefit to be gained in women over 60. And I think definitely from a bone perspective, we do know that when women go on to HRT, their bone density does improve. I think the reason we use it as a treatment for bone density under 60 is because of the slight risk of introducing it later in life, but it does still have that benefit. So I definitely have women who I have started HRT on who have been in their mid-60s. It's just about weighing up the individual risks and benefits for that individual person, and then them being able to make a decision as to what they feel they would like to do. I don't ever sort of say no to somebody. I think it's about a balance of risk and benefit, really.
One here, if your blood pressure went up with the combined pill, is it a risk taking HRT regarding blood pressure?
No, so there isn't actually any evidence to show that HRT makes your blood pressure go up. So the pill it can do. We generally do check blood pressure. It's like one of the things that we always check before starting someone on HRT. But I think it's more of an opportunity just to check someone's blood pressure, because having high blood pressure doesn't give you any symptoms, but it is a risk factor for sort of cardiovascular disease. So I think almost what we're doing is taking the opportunity to identify high blood pressure in someone who maybe doesn't know they have it, rather than it being, oh, we can't give you HRT, or the HRT is going to make this worse. It does potentially affect the choice of HRT that we might want to use. So if somebody has very high blood pressure, I maybe would be thinking more on the lines of giving them what we call a transdermal form of HRT, so through the skin, to minimise any sort of clotting risk that can potentially be worse with people who have high blood pressure. But as long as it's treated, then it's absolutely fine for us to use HRT in people who have a history of high blood pressure.
And are there any links between HRT and alopecia?
So hair change is quite complicated. So alopecia and hair loss is quite complicated, and there are definitely hormonal triggers for it. Stresses on the body can also trigger it. It's a difficult one, and I know a lot of women do talk about hair change and around menopause, and hair change in general is very common, and increased hair loss is common. HRT can actually improve that. It is a bit variable though, and I think with alopecia particularly, that's a little bit more of a complicated condition. And I'd probably, if I was going to introduce HRT in someone who had struggled significantly with alopecia, I'd probably want to start them at quite a low dose and then gradually increase it, so that we're not giving them too much of a sort of sudden increase in hormone. But hair change definitely is linked with hormonal changes, and testosterone as well can be a factor there. So it can be beneficial actually in some of those situations.
Referring back to how you referred to HRT as being very positive, we've got a question here. Would you suggest HRT even if you have no adverse menopausal symptoms? That's an interesting one.
Yeah, so that's quite a common question actually. I sort of managed to back myself out of it a little bit by saying that most women, if you actually go through the 45 different symptoms that women experience at the time of perimenopause and menopause, most women will probably find that they are actually experiencing things, but it might not be impacting on them. You know, they might be managing it absolutely fine. So I think it's difficult to say that there's women who don't experience any symptoms. I think that's actually very, very rare for that to happen. I suppose it depends on how much the symptoms are troubling you and how much you might want to consider using HRT. But I do have quite a low threshold, and I think really because of the additional health benefits that HRT does have to offer, I think that for the vast majority of women, the actual benefits of it far outweigh the risks, even if they are not really experiencing any major symptoms. So I do have some women who I've seen in my clinic who think actually they're not really troubled by their menopause, but they've read about the sort of heart and bone health issues and are keen to use HRT for that purpose. It's tricky because the NICE guidelines really say we should be prescribing HRT for symptom control. But like I say, I think for most women, if you actually go through the whole list of things, I think you'd be hard pushed to find someone who says they don't have any of those symptoms. And if they don't have any of those symptoms, it's likely that maybe they're not actually at menopause yet. So maybe that was me backing out of that question a little bit.
We've had several questions come up about family history of breast cancer and HRT. So perhaps we could address that.
Yeah, sure. So that's always quite a bit of a challenge. And a lot of women get told if they've got a family history of breast cancer that they can't have HRT. And that upsets me a bit, because I don't think we should be saying anybody can't have something. Again, it's about kind of the risks and benefits. What we know with HRT, if you've got a strong family history, and maybe you might have already been seen in a sort of a clinical genetics setting and been told that you've got a high risk of cancer, and you might be told that you need to have regular mammograms and things like that. It is that family history that is by far the biggest risk factor for you. So as we've shown in the data about the risk of HRT, the actual increased risk of breast cancer associated with HRT is very small. And when you put it into comparison to someone who's already got a high risk because of their family history, the overall risk is unlikely to change significantly by introducing HRT, because their baseline risk is already significantly elevated, and the addition of HRT is not going to make a huge difference to that. So for a lot of women actually with a family history, if they are symptomatic, I am quite happy in sort of talking through using HRT with them. I generally encourage them to go for a body identical preparation, because as I said earlier, we know that the new data coming through for that talks about how the body identical preparations actually don't have any increased risk of breast cancer for the first 5 years of using them. So in anyone who's already got a high baseline risk, obviously wanting to minimise that risk as much as possible. So that would be what we would recommend. There's a really good book which is written by an oncologist in America called Avram Blooming, and the book is called Estrogen Matters. And that book really lays out all the data about HRT, and it particularly talks a lot about breast cancer risk, because that's something that obviously I'm doing quite a lot in the breast unit. And I think that's a really useful book if anyone's particularly concerned about that.
And will you be able to give us a link to that I can actually send out?
Yeah, sure. I think
that would be great. We've got a question here. Will testosterone encourage facial hair to grow?
Yeah, so that is one of the side effects that I do say to women is possible. So greasy skin, hair growth, potential increased facial hair, and where you actually apply the testosterone, sometimes the hair can thicken. It's unusual to get these sort of side effects because the dose that we use is is physiological level for what women should have. And as long as we're not using too much, excuse me, then actually that shouldn't be too much of a problem. But sometimes some women will notice that, and if they're very sensitive to hormonal changes, potentially that can increase. So that is always something I do sort of warn women about, the potential for that with testosterone, yeah.
We've had several questions pop up about HRT and weight gain. Are they linked?
So I saw that just pop up then. So there isn't actually any evidence that HRT makes you gain weight. It's the same actually with most contraceptives as well. I think a lot of women blame contraceptives for weight gain, and actually the only contraceptive that has evidence for weight gain is the injection form. Weight is very complex in how your body sort of controls your weight. But what we do know is around menopause is your metabolism starts to change, and the way in which your body kind of stores weight, stores fat, and things like that do start to change. And so weight loss and weight management is much more difficult once you approach perimenopause and beyond. And often what I say to people is kind of what you might have previously done to lose weight is almost what you need to do now just to kind of keep your weight stable because your metabolism has changed. HRT doesn't cause weight gain, but it's not, I also don't say it's going to help you lose weight, but it can sometimes help with weight management, because if it's stabilizing your hormones, then sometimes that can help with kind of helping with the metabolism, and sometimes it can make weight management a bit easier. Sometimes people do retain a little bit more fluid with certain HRT if they're very sensitive to it, and suppose that can potentially make it appear as though they've gained weight, but actually, yeah, there's no evidence that it causes weight gain.
If the pill made you feel sick and exhausted, would HRT be the same?
So this is a common issue that I have with lots of women who struggled with the pill when they were younger. What I often say is that the pill contains very different hormones to what's in HRT. Yes, they both have an estrogen and a progestogen or progesterone within them. Well, actually, the pill contains very synthetic forms of hormone, as we were sort of saying before. They need to be synthetic and strong acting because they're working to stop you ovulating and to work as a contraceptive, but because of that they're not natural, and women are more likely to get side effects from those. So in someone who has maybe struggled with the combined pill, I'd be encouraging them to think about using these body identical forms of HRT, because they're chemically the same as your body's natural hormones, so they're more likely to have a lower sort of side effect profile. So a lot of women I have that really didn't get on with the pill have been absolutely fine on using these preparations. So I would say struggling with the pill is not a reason to think that you can't use HRT, definitely.
That's excellent. Thank you so much, Susie. Sadly, we have run out of time, and I think we're going to have to do something else on this because there are so many questions.
I was trying to look through the questions. There's hundreds.
I know, and it's great. But thank you, Susanna, for such an amazing and really informative presentation and Q&A today. As you all probably know, we've had unprecedented demand for this webinar, and such is the interest in the menopause that we're looking at continuing and doing a menopause series, because I think it's really filling a gap, and it really is affecting, ultimately 50% of the workforce at one time or another. So if anybody watching has any ideas what you would like to see, do respond to my email when I send you a link to this recording, and I'll send any links that Susanna also wants to include in that, and we'll have a look. But we want to supply what you want and what you need. So Thank you to all of you who've joined us today, and all of you who are obviously subsequently tuning into the recording. Our next CBC Wellness Campaign webinar is a mindful lunch, blissful, at 12:30 p.m. on the 1st of June, and I'll send you the details of that with the link to the recording of this webinar as well. In addition, we're also starting a Menopause Cafe on the Cambridge Biomedical Campus. Now, this is going to evolve over time. It might not be exactly what you particularly need at the moment, but we want to listen to what you want and give you what you want. So if you can possibly pop in tomorrow, that's Tuesday, 24th of May, in the cafe at Cancer Research UK on the Cambridge Biomedical Campus at 3 o'clock. No, it's a bit of a strange time, but we've got to start somewhere. You'll all be welcome. We want to hear what you want and put on what you want and try and get some support for people. So it's lovely to have seen so many of you attending again today. Thank you. And thank you again to Susanna. This has been absolutely wonderful. Thank you, everybody, and goodbye.